2 years into the pandemic, the shadow of COVID-19 still shrouds the world. We have now realized that it is actually the airflow which is the most important factor in transmission, more so in closed spaces. Since the dynamics of airflow and airborne particles remain invisible, we will need to think out of the box in order to make our workplaces much safer. Looking into the shadows, airflow dynamics in ophthalmic practice. Several engineering techniques have been applied to examine the characteristics of airflow and human respiratory activities in laboratories. One such non-invasive imaging is the Schlerin imaging technique. We took this technique from the laboratory to the clinic and the operating room and created an in-house apparatus. This allowed us to analyze otherwise unexplored aspects of airflow dynamics in a real-time clinical setting. Schlerin imaging, the setup in clinical practice. A telescopic mirror was stabilized on a table. Aluminium foil was then wrapped around a small LED light source to create a pinhole that would allow only a narrow beam of light to pass. A light block in the form of a razor blade mounted on a styrofoam block was placed just adjacent to this light source. The light beam reflected from the mirror falls onto the edge of this razor blade. Now the blade was placed in such a way that it bisects the reflected beam of light, allowing only the upper half to pass. Positioned directly behind this light block is a digital SLR camera, which is focused at objects immediately in front of the mirror or the test area. If there is any change in the refractive index of the air within this test area, the image of the point light source will be deflected slightly. The deflected image is then captured by the camera and appears as additional light streaks. Simply speaking, this is the Schlerin effect. What we found in the outpatient clinic. When the patient did not wear a mask, there was a jet-like stream of exhaled air from the patient's mouth and nose during normal breathing, talking. With a cloth mask, there was visibly not much change in this stream of air. Wearing an N95 mask visibly dampened the force of this exhaled air stream and reduced its traveling distance. Not surprisingly, when the nose clip of the mask was not properly apposed, there was significant air leakage from the upper border of the mask. Now look how taping the upper edge of the mask around the nose significantly dampened this leakage. We also imaged the airflow when a plastic face shield was held close to the patient's face. As you see, there is no forward transmission of the airflow beyond this mechanical barrier. Impact of room air circulation in the outpatient clinic. With the ceiling-mounted air conditioning unit turned off, there was free flow of exhaled air from the patient towards the surgeon. Next, the air conditioning is turned on and the patient made to sit directly under its draft. One can clearly see that this downward draft of the air conditioning both dampened and dissipated the patient's exhaled air away from the surgeon. What did Schlerin imaging show us in the operating room? Here again, when the patient wore a mask, the airflow stream was dampened yet not eliminated. A loosely fitted upper edge of the mask led exhaled air to flow directly towards the surgeon and the microscope. Covering the eye with an impermeable drape, which has an adhesive around the periocular area, eliminates any visible dissipation of airflow. Impact of room air circulation in the operating room. Turning on the overhead laminar airflow resulted in a high-pressure draft of air flowing downward, and this drastically dampened any visible exhaled airflow both with and without a mask. how did Schlerin imaging help us? The Schlerins imaging system allowed us to visualize normally invisible airflow dynamics in a real-time clinical setting without the use of potentially toxic gases or tracers. Air moves within hospital spaces due to several factors, including ventilation, the movement of people, and buoyancy-driven flows generated by heat of people. During most ophthalmic diagnostic and surgical procedures, the distance between the patient and the eye care provider is small and the duration often long. Therefore, we need to take the right precautions to safeguard ourselves and our staff from the airborne infectious diseases. Here are some simple measures that can easily be incorporated in one's daily practice and which will go a long way in reducing infection transmission. Ensure a snug fit of the mask around the nasal bridge. A simple step of taping the mask around the nose for both the healthcare provider and the patient will help reducing transmission of aerosols and airflow, thereby reducing contamination of humans and surfaces. Incorporation of mechanical barriers such as face shields and larger sized slit lamp breath plates, particularly at times when infections are peaking. A forceful draft of air flowing onto the examination and surgical area will significantly dampen and dissipate the travel of exhaled airflow towards the eye care provider. If in a real-world scenario, the surgeon and patient cannot be placed directly under a vertical draft of air, we recommend placing a fan such that the draft is directed towards the patient's face. Use impermeable surgical drapes with a strong adhesive to prevent leakage of airflow. Because, in the end, everything we see is actually a shadow cast by that which we do not see.